This continues the video series on head impulse testing. Part 2 describes the test parameters that are used to quantify the video head impulse test and outlines the interpretation of the results. If you have not watched the first part of this video series, please do so before continuing with Part 2. Many of the concepts in this part require knowledge of the underlying physiology. In order to interpret the head impulse test, several parameters have to be evaluated both qualitatively and quantitatively. The most important is the presence or absence of catch-up saccades. When they are present, a number of questions have to be answered. In which direction of head impulses are they present? What's the direction of the saccade itself? Is it in the same direction as the VOR eye movements or in the opposite direction? Are the saccades overt, covert, or a mix of both? How consistently do they occur? Do they occur in almost every head impulse to one side, or do they occur infrequently and inconsistently? What's their latency? And finally, what's their velocity or amplitude? The second test parameter is the VOR gain, which is defined as the ratio of VOR or slow eye movements to head movements. VOR gain can be calculated based on the head and eye velocities, positions, or accelerations. As we will see, it makes a difference which method is used. A related parameter is the gain asymmetry, which is defined as the difference between rightward and leftward VOR gains. In this case, and for the rest of this presentation, the terms rightward and leftward are used to signify if the head impulse is toward the canal on the right side or the one on the left side. That means the term applies for both horizontal and vertical head impulses. The last parameter is the shape of the VOR eye movements. This parameter has not received much attention in the literature, but it can be very helpful in distinguishing unilateral from bilateral lesions. We need to know if the VOR eye movements during head impulses are approximately proportional to the head velocity, or are they saturated or clipped. Most of these parameters can be examined qualitatively, but a few that are shown here in red have to be quantified. We will discuss each one of these parameters in more detail. But first, we need to understand the contribution of different mechanisms that participate in the head impulse test. Both the visual and vestibular systems are involved in head impulse testing. But as we discussed before, the visual system is much slower than the vestibular system. So the key to the head impulse testing is to use fast enough head velocities that are outside of the operational range for the visual system. For lateral vHIT, the responses for head velocities below 50 degrees per second are mediated entirely by the oculomotor system, mainly the tracking, also known as the pursuit mechanism. For head velocities between 50 to 100 degrees per second, both oculomotor and VOR mechanisms contribute to the responses. The ratio depends on the patient's age and other factors. So in order to test the VOR, the minimum acceptable head velocity is about 100 degrees per second. The maximum head velocity is around 250 degrees per second. Some people advocate testing the patient with higher head impulse velocities of up to 300 degrees per second, but one has to be cognizant of the safety issues, especially in the older patients. For vertical head impulse testing, that's RALP and LARP, the responses for head velocities below 50 degrees per second are mediated by the oculomotor system, and for head velocities above that by the VOR. So to test the VOR in RALP and LARP, the minimum acceptable head velocity is about 50 degrees per second, and the maximum is around 200 degrees per second. As it was discussed in Part 1, head and VOR eye movements do not exactly match during high-velocity head impulses, even in normal individuals. That's because the inhibitory responses saturate, and the neural command to the oculomotor system is not proportional to the head velocity. Of course, this difference is small in normal individuals, but it can still cause catch-up saccades. So not every catch-up saccade indicates an abnormality, and it must meet a certain criteria before it's considered to be abnormal. In general, pathologic catch-up saccades can be identified based on their consistency, direction, latency, and velocity profile. There have not been too many large-scale studies, and those that have been done so far have not fully established the normative limits for catch-up saccades. So identification of the abnormal catch-up saccades is still a matter of clinical judgment. The first rule for identifying abnormal catch-up saccades is that they occur consistently. If you see catch-up saccades in a small percentage of head impulses, that's not likely to be significant. Abnormal catch-up saccades are usually in the same direction as the VOR eye movements. That's because the eye movements usually fall short of the head movements, and catch-up saccades are generated in the same direction to reset the eyes on the target. In theory, one could see catch-up saccades in the opposite direction if the VOR gain is too high and the eyes get ahead of the target. But that type of saccade has not been reported so far. So for now, if fast eye movements occur in the opposite direction of the VOR eye movements, they're not likely to be catch-up saccades. So if they're not catch-up saccades, what could they be? Well, as we will see, fast phase of spontaneous nystagmus is one possibility, and there may be others. Catch-up saccades have a very specific time window because of the cortical level involvement. We know that more than one catch-up saccade can occur during the same head impulse. The very first one of these typically occurs within a window that starts about 100 milliseconds after the onset of the head impulse and extends to about 100 milliseconds after the head comes to a stop. The exact limits of this time window are still not fully established in large-scale studies, and again, one has to rely on clinical judgment when deciding if a catch-up saccade meets the timing requirement for abnormality. If there's a second catch-up saccade during the same head impulse, it usually has the same intersaccadic latency and should occur about 100 milliseconds after the first one. Fast eye movements that occur outside of that specific time window are not likely to be abnormal catch-up saccades. As we have seen before, normal individuals can have catch-up saccades, especially during high-velocity head impulses. The velocity of these catch-up saccades, as you can see here, is usually much smaller than the peak head velocity because the difference between head and eye movements is usually small. On the other hand, the velocity of abnormal catch-up saccades is much larger, and it's usually comparable to the head velocity. A few studies have attempted to establish the normal limits for the velocity of catch-up saccades, but unfortunately, they did not compare to the head velocity in establishing these limits. So again, this remains a judgment call. It seems that a good benchmark would be if the catch-up saccade velocity is less than half of the peak head velocity, it is probably not significant. The other parameter that's used in interpretation of vHIT is the VOR gain, which is defined as the ratio of VOR eye movements over the head movements. The VOR gain quantifies the relationship between head and eye movements, and in normal individuals should be close to 1. Interpretation of the VOR gain can be confusing if one does not consider the underlying physiology. For example, if a patient has a complete loss of function on one side, the VOR gain for head impulses to that side still would not be 0. That's because the inhibitory responses from the intact side can still contribute to the VOR gain, although the contribution is small. The interpretation of VOR gain becomes even more complicated because it can be calculated many different ways, and how it's calculated affects the outcome. The common methods for calculating the VOR gain can be based on velocity, position, or acceleration. We'll look at these methods in a moment, but let's keep one important rule in mind. When comparing the VOR gains either between different patients, or in the same patient in different times, or in the same patient between rightward and leftward head impulses, the comparison is meaningful only if the peak head velocities are approximately the same and within the optional head velocity ranges that were described before. The most common method for calculating the VOR gain is based on velocity. For a given time, which is usually around the peak head velocity, the head and eye velocities are determined and the ratio is calculated as shown here. Sometimes the VOR gain is calculated earlier to make sure that there is no chance of encountering a covert saccade around that time. Calculating the VOR gain at different times is usually not an issue as long as the head and eye velocities are proportional, as they are in normal individuals or during head impulses toward the intact side. But the head and VOR eye velocities are not always proportional. An example of that is during head impulses toward the site of lesion. So in a patient who has a given vestibular loss, the value of the VOR gain is different depending on at what point in time the gain is calculated. For example, here the VOR gain is calculated at 40, 60, or 80 milliseconds after the onset of the head movement. Because of the nonlinearity of the responses, the VOR gain is going to be different for these time intervals. This is especially problematic when comparing the right and left VOR gains because the response to the intact side is proportional to the head velocity and not affected by when it's calculated, and the response to the damaged side is nonlinear and the VOR gain depends on what time interval it's calculated. To avoid the problem with the velocity-based calculation of the VOR gain, one can use the difference in the final positions of the head and eye as a way of determining the gain. So here, right at the end of the head impulse, the position of the head and the eye are determined and their ratio is used to calculate the VOR gain. In practice, we can use the area under the respective velocity curves to determine the head and eye positions at the end of the head impulse. This is the method that ICS Impulse uses, and it seems to be the more logical way of defining the VOR gain. After all, the position difference is what triggers the catch-up saccades, and the position-based VOR gain directly represents that difference. The only complication with this method is when covert saccades are present. To estimate the VOR gain properly, the saccade has to be removed to determine the VOR eye movement during the head impulse. This is similar to removing the fast phases of nystagmus when analyzing the slow phase eye velocity. It can be done, but the gain estimate will be affected if the software fails to identify and properly remove the covert saccades. Another method for calculating the VOR gain is based on the acceleration. So one determines the peak head acceleration, which occurs around halfway between the onset of the head movement and the peak head velocity. Then the eye acceleration around the same area is calculated and the ratio is determined for the VOR gain. This approach was used in early studies of vHIT, but it has the same issues that the velocity-based methods have, and it's more complex. So this method has been abandoned for now and will not be discussed here. What does the VOR gain pattern look like in a normal individual? VOR gain in normal individuals is about 1 for head impulses in the direction of both tested canals and begins to decline with increasing head velocity. Note that the interpretation should be limited for the VOR gains that are within the optimal head velocity range. In patients with unilateral vestibular deficits, the VOR gain may start close to 1 for head velocities that are below the optimal range. But for head impulses toward the site of lesion, the gain declines rapidly with increasing head velocity. The VOR gain pattern for head impulses away from the site of lesion is similar, but both the initial gain value and the rate of decline are not as much as those for head impulses toward the site of lesion. This slide demonstrates two important points. First, if the head velocities are low enough, even patients with unilateral lesions will show VOR gains close to 1. Second, the VOR gain does not represent the function of a single canal or its neural pathway. It's always a combination of the responses from both involved canals. In patients with bilateral vestibular deficits, the VOR gain is significantly below 1 for head impulses both toward and away from the site of lesion. For complete bilateral loss, the VOR gain will be close to 0 bilaterally. When the loss is bilateral but partial, or when one side is affected more severely, the VOR gain pattern may be similar to the gain pattern for unilateral vestibular deficit. But as we will see later, they can be differentiated based on the shape of the VOR eye velocities. Now let's go through a step-by-step process to interpret the vHIT results. First, determine if catch-up saccades are present, and if so, are they abnormal? Use the guidelines for consistency, direction, timing, and amplitude. But remember that the norms for these parameters are still a work in progress, so you have to use your clinical judgment. If there are no catch-up saccades, check the VOR gains. If they are close to 1 and within normal limits, then consider vHIT to be normal. In ICS Impulse, the normal range for VOR gain for lateral impulse is 0.8 to 1.2, and for RALP and LARP is 0.7 to 1.2. If the VOR gains are abnormal, but there are no abnormal catch-up saccades, that usually means presence of an artifact or something very unusual. For example, if the patient has saccadic palsy and can't generate fast eye movements, then you may not see any saccades. But these cases are extremely rare and they're easily recognizable. As for the artifacts, we will discuss that in part 3. So here's an example of a normal response. There are no clear catch-up saccades and the VOR gains are close to 1 bilaterally. In this case, head velocities are approximately equal for right and left head impulses, and they're mostly within the optimal range. Also, there's no other sign of artifacts. Complete absence of catch-up saccades is actually not that common. Here's an example where the subject does have catch-up saccades, but the question is, are they abnormal? It seems like the saccade velocities are much smaller than the corresponding head velocities. As we discussed before, it's not likely that these saccades are abnormal. Since the VOR gains are also close to 1, this is most likely a normal vHIT. If abnormal catch-up saccades are present, determine if they're present in one direction only or to both directions. If catch-up saccades are present in one direction only and the VOR gain is abnormal for that side, then that's consistent with the unilateral lesion. For lateral head impulses, abnormal results for rightward head movements indicate the lesion in the right lateral canal or its afferent neural pathway, which in this case is the superior portion of the vestibular nerve. And abnormal results for leftward head movements indicate the lesion in the left lateral canal or its afferent neural pathway. For RALP and LARP, abnormal results for downward head movements indicate a lesion in the anterior canal, which again goes through the superior portion of the vestibular nerve, and abnormal results for upward head movements indicate the lesion in the posterior canal or its afferent neural pathway, which in this case is the inferior portion of the vestibular nerve. Significant gain asymmetry is usually present with the unilateral deficit pattern with lower gains for the site of lesion. The status of the contralateral VOR gain is not important for the interpretation. It can be within normal limits or not. Here's an example of a patient with a unilateral vestibular dysfunction. Catch-up saccades are present for rightward head impulses. They're mostly covert saccades, followed by secondary overt saccades. The VOR gain is significantly lower than 1, and there's a large gain asymmetry. These findings all indicate a lesion involving the right lateral canal or its afferent neural pathway. The VOR gain for the leftward head impulses is normal here, but its status is not relevant to the interpretation of this case. Interestingly, this patient also has abnormal responses for head impulses toward the right anterior canal. This demonstrates that the same rules that we considered for the horizontal head impulses can be applied to the interpretation of vertical head impulses as well. Based on these results, this patient most likely has vestibular neuritis involving the superior portion of the vestibular nerve. To confirm this interpretation, it would be helpful to have the results of the OVEMP and CVEMP tests. One would expect to have normal CVEMPs and abnormal OVEMPs in patients with superior vestibular nerve neuritis. If abnormal catch-up saccades are present in both directions, examine the shape of the VOR eye velocities for each direction. If VOR eye velocities are clipped or saturated for one direction, but they're proportional to head velocities in the opposite direction, then the results indicate a unilateral lesion on the side of the clipped or saturated responses. This type of finding is usually accompanied by a significant gain asymmetry with the lower gain for the side of lesion. Again, the interpretation is the same regardless of what the status of the VOR gain is for the contralateral side. If VOR eye velocities exhibit clipping or saturation in both directions, consider vHIT consistent with bilateral loss of function in both involved canals or their afferent pathways. This finding is usually accompanied by a bilateral reduction of the VOR gain. Here's an example of a patient who has abnormal catch-up saccades to both directions, but they are more significant for rightward head impulses, and the VOR gain is asymmetric with significantly lower than normal value for the same direction. If we examine the VOR eye velocities for the rightward head impulses, we see that they are saturated or clipped. On the other hand, VOR eye velocities for the left side are smaller than the head velocities, but they still look proportional to the head velocities. In fact, the difference between the head and eye velocities is large enough to generate a catch-up saccade. As we discussed in part 1 of these presentations, this is not unexpected, especially for severe unilateral deficits. So overall, this finding is consistent with the unilateral vestibular lesion on the right. The VOR gain for leftward head impulses is abnormal, but that doesn't change the interpretation. The next example also shows abnormal catch-up saccades for both rightward and leftward head impulses. But the difference between this case and the previous example is that both VOR eye velocities appear to be saturated or clipped. Also, there's a VOR gain asymmetry, but it's relatively small. This pattern indicates a bilateral vestibular deficit. The loss is partial because total loss of bilateral vestibular function would have resulted in VOR gains of near zero. Interestingly, this patient exhibits the same type of partial loss in all vertical canals. This is a hex plot of the results where the bars in the middle represent the VOR gain for each direction. As you can see, the VOR gains toward all 6 canals are reduced. The exception is head impulses toward the right anterior canal, shown in green here, which seems to be borderline. The 3D representation of the results shows that the VOR eye velocities are clipped or saturated for all 6 directions of head impulses. This bilateral deficit pattern is quite consistent with the patient's history, which includes exposure to systemic ototoxic medications. Sometimes spikes that represent fast eye movements are present in the eye velocity tracings, but if they're in the opposite direction of the VOR eye movements, then they're not likely to be catch-up saccades. The most likely cause of this type of spike is the fast phase of spontaneous nystagmus, which is common in patients with an acute peripheral vestibular lesion. Here's the explanation of how spontaneous nystagmus can affect the head impulse test results. Fast phases of spontaneous nystagmus, shown here with dashed lines, will appear as spikes in the eye velocity tracings. But unlike catch-up saccades that have a specific time window, fast phases of spontaneous nystagmus can occur any time, before or after or even during head impulses. The velocity of spontaneous nystagmus fast phases is usually much smaller than the velocity of catch-up saccades. For head impulses toward the site of lesion, the direction of spontaneous nystagmus fast phases is the same as the catch-up saccades. As a result, they are intermixed with the catch-up saccades and not easily distinguishable. But the key to identifying them is that the spikes are in the opposite direction of the VOR eye movements when the head is moved away from the site of lesion and toward the intact side. Here's an example of a patient with an acute unilateral lesion on the left. The presence of abnormal catch-up saccades and below normal VOR gain for leftward head impulses are consistent with this interpretation. The spikes for the rightward head impulses are in the opposite direction of typical catch-up saccades. These are fast phases of a right-beating spontaneous nystagmus. Fast phases of this nystagmus are also present for leftward head movements, but they are intermixed with the catch-up saccades. In summary, when catch-up saccades are present that meet the abnormal criteria for consistency, direction, timing, and velocity, then vHIT should be considered abnormal, regardless of whether the VOR gain is normal or abnormal. Abnormal vHIT is a very specific sign of a lesion involving the ipsilateral semicircular canal or its afferent neural pathway. Conversely, if the VOR gain is abnormal, but there are no abnormal catch-up saccades, one should investigate this further for a possible sign of artifacts. VOR gain is a complicated parameter that depends on the method of calculation and the underlying test conditions. It doesn't represent the function of a single canal, and it's always influenced by both canals that lie in the plane of head movements. Finally, valid head impulse testing requires head velocities to be within a specific range and right and left velocity profiles to be approximately the same. Otherwise, interpretation of vHIT will not be accurate. This concludes the second part of the video presentations on vHIT. The next part will concentrate on how to perform the test in order to obtain valid results and how to identify and avoid common artifacts.